once again, welcome. This is the fifth of our ecosystems and pop-up ecosystems we run, and this one is particularly focused on home and social care. So, and we're looking at using this from a specific focus for our ecosystems. I'll have the next slide, please. What are pop-up ecosystems? Just briefly, for those people who've not been to them so far, if you've been involved with our ecosystem network for some time, you know these are where we bring stakeholders together to target regional health challenges. Never has there been such a challenge now internationally as COVID-19. Our ecosystems are continuing to break down silos, transform healthcare delivery, and also still create economic growth during this crisis. But for now, this will be online and will be multi-ecosystem. By multi-ecosystem, you can see the length and breadth of our ecosystem network. We currently are still growing. People are still very passionate about forming and setting up ecosystems. And so we're looking to include input, and we have done so far, from a wide variety of ecosystems. And what we've done is to be able to set up and build a thematic program of pop-up ecosystems, reflecting the fact that people will be working online. And here's some details of our program now. You can see we've got very, very shortly we'll be having the first of what I think will be an exciting program targeting how Canada and Europe will tackle COVID-19, coming up on June the 3rd. We've also got one targeting dementia on June the 10th and how that's changed. Before that as well, we also have one which is in 2 weeks' time on mental health. And then we've also got a confirmed date for now for our data donation program. Because we're also building more into our program. And by building more, that gives us an opportunity to expand out and cover those areas we know which will be of higher interest to our ecosystems and our members. So we've got this week, we've got our first Finnish network of ecosystems meeting happening on Friday. You can find out the details online for that. We're also looking to target the area of matching demand and supply. We've got a very exciting ecosystem plan with our colleagues in Australia, again, like the one in Canada, targeting Australia and Europe. We're also going back to colleagues in Latin America who are very keen to get involved. And also, we think that the mental health thing will become very, very much more of a focus as people see some of the impact and the damage and the affect this is having on people's mental health and well-being. And hopefully, this is exciting for one particular man in the room, we'll be having our first pop-up ecosystem targeting Greece. Added to that, we're bringing in the role of a global connector, and we've been recently meeting with colleagues from Africa, America, and the Commonwealth to build what we call our global connector partnership, which will be targeting more and explaining more later. But let's return to the topic of the day. The topic for today is home and social care. My background's in social care and home care as a psychiatric worker for many years and a street worker. So this is very important for me to target this area. And you'll have seen in various countries the crisis being ripping through our hospitals and our lives, and very specifically in our care homes and our domestic care provision. And the headlines have been very, very, very close and targeting this. So we brought together what we hope are an exciting set of panels, and the people you'll see here now have got a very, very different level of experience from a wide variety of countries. I've got a slide here with the pictures of the colleagues who are on the call. Next slide, please. Ranging from Italy, Greece, Spain, and the UK, as well as, for the first time, from our new upcoming ecosystem in Canada. That's it from me, you'll be glad to know. Let's move on with the agenda. I'd like to welcome our first speaker, please.
Thank you, Adi. My name is Theodore Vondetsianos. I'm from Athens, Greece. I'm a clinician, pulmonary physician, And the last 20 years, I'm occupied with advanced outpatient care of multimorbid patients. We are doing this using the ICTs, the modern ICTs, in e-health unit that we have established in my hospital, in Sotiria Hospital. I'm also the coordinator of the Greek network of EIP on active and healthy aging. I'm sure that you are all aware of this major initiative of EU. So, which is the current need due to the pandemic? The need to triage and treat a large number of symptomatic patients or self-isolated suspect cases from a distance. The protection of the vulnerable population, who are the elderly and the patients with multiple chronic diseases, from infection of the virus, when they look for healthcare services in the places of their delivery, which are the hospitals. It also is the creation of capacity in hospitals and the reduction of the strong burden for the hospital staff. And finally, and more important, is to mitigate the danger of converting hospitals into sources of virus transmission to patients and the staff, as it was the case in northern Italy. The rationale, the above aim, the next one, okay. I'm sure that you all agree that the above aims can only be efficiently achieved by the implementation of innovative healthcare models and practices enabled by the adoption of today's smart digital technology possibilities. Next one, please. So, under this pressure, a variety of stakeholders of our reference site in Athens came together to proceed to a collaborative proposal to prepare ourselves for the next autumn. As you may know, we managed to avoid a serious crisis, at least at this phase, so we're preparing ourselves for the next open. The collaborating partners are coming for the public sector, mainly from the First Regional Health Authority of Attica, from academia, including the Medical School of Athens and Thessaloniki, the Technical University of Athens and Western Macedonia, and the Nursing School of Western Attica. From the social sector too, with the main representative, the municipality of Athens, which is the leader of our reference site. And finally, from several scientific societies and NGOs, as it is our network, the e-health forum, a forum of multiple e-health stakeholders, as well as the HL7 in Greece. Next, please. So, who will be the beneficiary patients? First of all, the outpatients with mild symptomatology of COVID-19 infection, and especially the frail, elderly, and multimorbid patients. Second, the outpatients with laboratory confirmed diagnosis of COVID-19 infection, but with mild symptomatology, which doesn't need the hospital admission. Third, healthcare workers with high risk exposure to COVID-19, when the isolation and active and frequent monitor at home is required. And finally, non-COVID chronic patients with multiple chronic disease who are nevertheless in the need of integrated care, and maybe early discharge to grant their hospital bed to coronavirus patients under this critical condition. There is really at this time a great need of these patients to have access to the traditional services, health services. Next, please. Who will be the beneficiary service providers by this new service? The health professional, mainly the health professionals of primary care. Second, the professionals of home care providers. The social professionals from community support points which have been developed from municipalities. The professional in care homes, very difficult situation, the care homes for these kind of patients. And finally, the patients themselves or suspect cases of patients themselves through direct access to our unit. Next, please. A brief descriptions of the services that we propose. The supported remote triage, keeping the patient at home through specialized artificial intelligence systems that have been especially developed for this purpose. The second, ICT-supported remote monitoring and home-based integrated care for the whole health problems of the patients. You note that they include the patient's health record, remote follow-up, critical biometers transmission, comorbidities management, as well as the whole coordinating needs horizontally and vertically to the health and social care system. There will be also psychological and empowerment of the patients and help in the everyday problem solving, as well as finally the support with specific guidance and empowerment of visiting home care teams. Next, please. This is a graphic representation of integrated care. To my estimation, it's a very good representation. It's not ours. It's coming from colleagues from the University of Barcelona. Next, please. Technologies. I'm sure that the most of you are quite familiar with all these characteristics of the technologies that we're going to use. And I think that these characteristics will be analyzed by next speakers. So I can proceed to the next slide. This is a graphic for our maturity estimation regarding the clinical, the business, the technology, and regulatory dimensions of what we're proposing. Next one. I would like, with this slide, to make some comments, mainly from a medical point of view. There are serious legal and safety issues in this kind of services. There have been a lot of proposals, and many of them does not address correctly serious quality criteria. So these services may be proved as hazardous for many patients, and that's why I would like to draw your attention at these issues. A second dimension is a strong leadership. Clinical, technical, and administrative inspired leaders are needed who will develop the appropriate strategy for implementation under the current or in development guidelines, because there are a lot of pending issues, or there are issues that are changed every day. Another specific dimension is the training to the staff, to the consulting staff, as well as for the patients who receive the services. Other operational dimensions of everyday practice, mainly the quality criteria. And finally, the very serious, always serious reimbursement and sustainability issues for this kind of services. Next, please. Expected outcomes. The main outcomes that I would like to stress is to develop services convenient for the people, especially the vulnerable people, to keep our hospitals clear, and also to use this pandemic as an opportunity window to have a great push for integrated care, so to have the opportunity to reshape the healthcare delivery in everyday clinical practice for chronic patients. It may also, this proposal, these kind of new services may be also useful for the needs of elderly people who are going to visit Greece or other parts of Southern Europe the next summer. And next, please, finalizing my presentation, I would like to say many thanks to Adi, to Brian, to eHealth Alliance, that they gave me the opportunity again, as it was the case in last September in Helsinki, when I represented the Greek Ministry of Health, so that I may repeat by this proposal the message that our country is back by now. Thank you very much, Adi. Thank you, all of you.
So thank you, everyone, for joining, and thank you, as always, ECH Alliance for the kind invitation to be part of this, in this webinar. In the next few minutes, what I'm intended to do is to share with you some. I apologize, I didn't introduce myself. I'm Esther Sargeda. I work for Untitled Healthcare, as you've realized, leading healthcare business in Spain. So basically, what I intended to do in the next few minutes is to share with you some initiatives, some interventions we've been seeing, so we've seen and delivered in the area of technology-enabled health and care services to face the current COVID-19 crisis, and hopefully to share some thoughts for further discussion with you all. So as it is well known, Spain is one of the most affected countries by the coronavirus disease outbreak, and all the people are facing significant risk, are at the top of the pyramid, developing severe illness if they contract the disease. And this goes with age, but also with pre-existing clinical condition. And this is not particular for Spain, but as we want to tackle this in here, this is what we are looking at. So elderly population with cardiovascular disease, hypertension, diabetes, and the whole range of other chronic conditions. But COVID-19 is not only affecting older adults' health status, but also those without the health and care resources and social structures that were contributing to their overall well-being, wellness. So we are seeing how healthcare is prioritizing acute and emergency care for COVID-19 patients. We are seeing how standard chronic care programs are put on hold, and that includes primary healthcare regular prevention programs, home care intervention, regular follow-up appointments, or rehabilitation programs. Also, social services are being particularly vulnerable to this crisis. And to be honest, not always considered in the initial contingency plans. There's no need to analyze what's happening in our care homes with very severe problems in coordinating an effective response with healthcare, and with the too late intervention from healthcare to deal with the internal complex situation. Also, daily care, domiciliary care, until today is most of it suspended until further notice. But on the other side, we've seen how COVID-19 has prompted like a sudden turning point into adoption of digital health and care technologies that has reshaped very rapidly how we delivered or how we provided care. We've seen numerous examples worldwide, also in Spain, with face-to-face visits to virtual consultation, virtual connection between people who was in hospital and their family members, visits to personal health folders, electronic prescription, so on and so forth. So how telecare and telehealth services are helping in this journey or in facing this COVID-19 challenges? What is happening around that is supporting our health and social care systems to face the challenges and to manage the crisis? It's been terrific how quickly telehealth managed service have been adopted, and somehow surprisingly, this adoption is mostly happening, in my opinion, not for COVID-19 patients. For those, we've seen a very high prioritization of local contact tracking or local location and contact tracking. But for those complex patients that have seen their expected healthcare support, their management being affected, so we've been collaborating, supporting, delivering remote clinical monitoring for example, for post-surgical patients to reduce their length of stay. We've been delivering home clinical telemonitoring for supporting complex chronic patients, in this case with asthma, avoiding hospital visits and potentially reducing the risk of hospital admissions. We're using clinical telemonitoring for those who live in care homes, using the clinical management and decision making for primary healthcare professionals that are the ones assuming now the clinical management of the users in care homes, and of course providing telehealth support, symptom checking for COVID-19 patients. Yeah, COVID-19 patients. Sorry for that. But not only, and that's what I think it's quite relevant to think about. You saw in, I think it was a couple of weeks or four, I don't know how when was that, my colleague James Champion from the UK, he shared some of the solutions we are providing to tackling, to solve those, to deliver those services. But for implementing those new services, it's not only choosing the appropriate, secure, and validated solution, that is obviously very relevant, but also understanding it as a fully new managed service. So implementing new models of care require, even if you have to do it quickly, require to go back and think the pathway redesign, the change management. It's not only doing the same, but virtually now. It's doing things differently, doing different things, and mainly stop doing those things that we do not need to do anymore. And something similar happened to in our Telecare service. In Spain, we're currently supporting 340,000 users 24/7 without proactive and personalized support. And of course, COVID-19 has had a big impact in
Esther, you've gone very quiet all of a sudden.
Here as well. Apart from ensuring the continuity of our operations and implementing our services, quite atypical because they do not include the ordinary technology, home technology, but make sure that we still provide the reactive and the proactive support with the well-being calls and the comprehensive service. And these services are still prescribed by social services in the local authority levels, by the social workers mainly. Other than that, we've had to implement a lot of operational measures in our response centers. So, for example, we had to develop protocols and new training materials for our response centers so they could deal with new situations, such as, for example, losing a family member without farewell, mourning, or burying, even the normal burying process. I also wanted to highlight the extreme positive collaboration we've been able to build with the emergency services, 111, 112, 061, depending on the region, so the telephone emergency help services. So we've agreed with most of them red lines to make sure we could properly manage the emergencies, so we get the proper response by them. And also we build some daily reporting for them so they can track our developments. The most difficult decision was whether to continue with the proactiveness of the Telecare service or prioritize the inbound calls, the emergency calls. And supported by evidence, we decided to continue with this proactiveness, with the outbound calls. So we did. We continued with the care support calls, with the abuse prevention calls, with the health advice calls. And when I say that we did it supported by the evidence, it's because Council research program that will be published in the very near future has developed an integrated and quantified map of the benefit domains that are potentially reliable on telehealth and telecare. And this research has been very, very interesting to conclusively demonstrate how effectively managed and integrated advanced telecare services can have a major impact in better support, delay of residential care, reduction in the demand of emergency health care resources, and also in efficiencies in the service delivery. So just to conclude, we all agree that COVID-19 is presenting the worst public health crisis for a generation, and technology can help to address some of those immediate challenges. But we will still probably need to go back to the model, because we all agree that the integration of health and social care now became urgent, and along with it, the need to innovate in the way we deliver care. So our thinking is that today is when we move from sometimes limited testing intervention to mainstream technology-enabled health and care services such as remote patient monitoring, telemedicine, advanced telecare, virtual care. So we want this transformation to remain. It's not only about adopting shiny new pieces of technology. It's about assuming the necessary care model transformation to make technology work and in its fully potential. And this is what we want to help from Council. Basically, we want to help on this model transformation for COVID-19 patients, but mainly for all our most vulnerable population. We want them to live at home for longer and to feel safe and secure while they live at home. So that's everything from my side. So happy to hear your questions.
Thank you very much for that, Esther. Very, very, very informative, and great to see a solid response from Tunstall in Europe.
Hi, I'm Steven from Canada. I'm a social designer at Présage, which is a social innovation hub for the Berthiaume du Tremblay Foundation. Can you see my presentation right now?
No, not just quite, no. Maybe you need to switch one of your screens around. I can see you, which is good.
Okay, and now?
No, it says waiting to view. If no, yes, something's coming. That's fine. Aging in community.
Okay,
once again,
good.
Stephen, the floor is yours.
Okay, thank you. So how can technology can help us? I'm just rereading that and seeing the mistake. Help us nurture resilient intergenerational connections, and you'll see that today I'm coming with some ideas and about responses, but also a lot of questions. So I come from the Bertillon du Tremblay group. So Présage is part of a cluster of organization and project, which is under the umbrella of the Bertillon du Tremblay Foundation, which has the mission of contributing to the well-aging of the seniors around the province of Quebec. Présage is the social innovation hub of the foundation that is focused on social participation. So you'll see that I'll speak more about social participation and also issues about mental health. And I'm also connected to the Quartier des Générations, which translates as Neighborhood of Generations, which is a social innovation living lab focused on plurigenerational living. So it's actually a neighborhood in Montreal where we do a lot of experimental approaches around senior living, as much in public housing than we do with long-term and a daily center. So we're all a connected cluster, and why I'm saying that is that I'm also sharing a view around diversity of the faces of aging. And so with our organization, we're connected to many realities, as much as the younger seniors to the one in long-term care. Also sharing a bit of the particular context of what's up in Quebec now in COVID for seniors. Just wanted to highlight that we have there's the particularity in Quebec, especially compared to Canada. You see that 18% of seniors live in private housing, as in the rest of Canada, it's only 6%, because seniors in the rest of Canada age more at home and with families. And also 6% are in long-term care facilities. And the funny thing is the only seniors we hear about in the news right now are the ones in those 6%. So we don't have a general view of what's happening in all the broader spectrum. And also bringing those numbers just to highlight that we have a particular context here of Quebec of having weak intergenerational connections. And that means that in this crisis right now, there's a lot of seniors that are not connected both technologically and to their community. Also, to bring more details in private housing, what happened in the last weeks. As COVID is seen a lot as a seniors problem, our response here was really directed to seniors, and there was a over restrictive quarantine enforcement, especially in private housing. And there's a lot of questioning right now around how this was applied in those residencies, and how it, in a way, didn't leave much place for autonomy for those people to choose themselves how they're gonna adapt to this crisis and how they're gonna confine themselves. So this brought higher solitude in those housing facilities. And as we have a lot of those in Quebec, that means that a lot more seniors in Quebec are at risk of catching the disease, because when it gets in those facilities, it quickly spreads. As it's the same in long-term care facilities. Also in Quebec, there's a story of decades of reform for those facilities, and we're really seeing right now how those systems were exasperated by those years of budget cuts, literally, and affected by labor shortage in the last years. We've been doing, in part of my work, I do some consulting, and I've been doing consulting in the last 2 years with those facilities, and we really saw how it was hard to innovate in a way, because there's a labor shortage and employees are exhausted, and they were exhausted even before the crisis. So just to highlight, like, just to give a quite of perspective of how it looks like in those right now. And people at home that just highlighting there's a high solitude. So all those numbers just showing the way that seniors might really be in a state of loneliness right now, especially in this crisis. So who can you turn to in time of crisis, especially in this kind of context with all those numbers and with this weakness of intergenerational solidarities? And also, we're connected to the nonprofit sector around the province who works with seniors. And most of the volunteers who work with seniors are in fact seniors. They're not the younger generations generally, which means that nonprofit and all the organizations that usually give a lot of care to seniors, all of their volunteers are in isolation right now. So there's a lot of people who can't help because they're kind of being forced into isolation. Also, there's a lot of, we're always only talking about the seniors that are afraid at home and kind of suffering from it. But also from our perspective, we saw a lot of seniors also rising to help because there's a lot also of more healthier seniors. Also monolithic views of seniors linked to one size fits all solutions. So this is really showing in how they applied confinement in all residencies. And even when you're in the state of isolation, some of the seniors that are living home alone and don't have really connections with families, there's a lot of people who were kind of forbidden to enter some grocery store because people were saying you should not get in it. It's not safe for you, which was a bit ageist and which really put people in vulnerable place of being disconnected from communities, but also not being allowed access to things. So it might be a heavy entry into the subject, but also I think it's good to look at those things right now to really see how we're gonna learn from that crisis for the future. What we've been, how we've been reacting collectively so far, and what we've been learning is that there's nothing like a good old phone call. Well, because Zoom is kind of our work standard, and we've seen a lot of projects who try to connect Zoom to connect seniors on Zoom, and were actually, if they were not already connected before the crisis, it's kind of a bit too late for some of them to kind of get into this technological learning process at a distance, because it's really easier for seniors who haven't had this contact to technology to really learn with someone. So also the limits of a Zoom call, like we've seen, I'm seeing for myself how much it's actually draining, energy draining and concentration draining to spend hours on Zoom calls. And yet some seniors don't have as much capacity to concentrate as we do. So using Zoom is not the best way also to get them connected all the time. And the way it's influencing our reflection in how we're going to adapt services is, by example, we're consulting with public libraries right now, wondering how we could adapt their services at a distance for seniors who are alone at home. And instead of planning an hour conversation around readings with seniors, we're trying to think of how could we maybe have a little call in the morning, and then people can do something by themselves in the day and get busy by themselves, and then maybe have a checkout at the end of the day. But just try to think differently about how we get them engaged with technology, and just be more sensitive around how their capacity and their also desire to connect with technology. If you pretend they are wise, why not ask them for advice and help now? To come back to this idea of how confinement was applied in Quebec, and as much as we talk about seniors as wise people who know things, we didn't ask them for how they wanted this to happen. So we've been holding circles weekly with a lot of people working in the nonprofit sector around the province lately, to kind of see what can we learn from this crisis, and what's happening right now, and how are we reacting, and really reacting and not thinking about things, and how we can, and how the ones of us who can't support directly can use their time to really reflect and see and take a step back. And we're really seeing this tension of navigating between the urge to protect and the right to autonomy, as I was saying in residencies, how people didn't have that choice to go into isolation, where I was in isolation as much as they did, but I have that perspective of choice, which really changes the mental state you're in while you're in isolation. And so, yeah, we're starting to really being kind of wondering what's going to be the impact on their mental health, and also the cognitive impact it's going to have of all that loneliness. I'm just seeing on myself how I'm losing track of time in this confinement. So people who are more vulnerable to cognitive losses, having this disconnect right now, where completely disconnecting them to protect them in a way is not going to protect everyone. Some of them are going to suffer more from cognitive losses that they would have from maybe being more at risk of catching in, but applying themselves their own rules. What do we move forward with? So we're maintaining virtual support with organization and people, and we're also setting up a proposition of online circles with residents of housing to kind of have those conversations with them and try to learn with them of what's happening from this crisis and how we can adapt differently when we're going to have the same kind of storm in front of us. We're setting housing as an innovation priority and preparing the field. So we have to respect those rules that are kind of restrictive right now, but we're also trying to see how we can find liberty within that and prepare the field for even, like, technology is the digital aspect, but it's also architecture, it's also systems and services and knowledge, and that's a part we're trying to work on. And also giving a new look at our technological projects, the needs we focus on, and the importance for a human touch. And as I was saying, just how people need to be connected, but they need to be checked on. They not only need to for us to read them a story on the phone, but they need to have a check-in before that and maybe connect with other seniors and talk about that story. So it's just bringing to us really the aspect of how can we use technology in a way that really helps connecting people, not only to us, but between each other, and really always have this kind of aspect of human touch that helps create community. Okay. And maybe to end, because I lost track of time. If loneliness is one of the most influential aging health factors, now more than ever, it's a time to worry about your neighbors and your own future, might I add. And finally, how might we fight the temptation of going back to normal? As I was saying, the normal for seniors is not really something desirable. So we have to strive for something different, as we kind of been offered this harsh reset button. And we face the harsh lessons of this crisis with grace and keep working toward aging in pluri-generational communities. So having seniors less in their own part of the cities all by themselves, but really connected with their families and communities. And just ending there when we share with the links to our websites. So I think I'm going to stop there.
Thank you very much for that, and very interesting to see a perspective and the impact on intergenerational communities there in Canada. So thank you very much for that. During your presentation there, we would have seen a screen just bob up, but for now we're going to move very, very swiftly on because we're losing a little bit with our time. We're going to introduce our speediest speaker on the planet, Jen from Elemental, who's known for her brevity and shortness of words. So Jen, Joanne, over to you. If you could share your screen, introduce yourselves, please, both of you.
Thanking you. So yeah, my name is Jennifer Neff, the co-founder and co-CEO of Elemental.
And I'm Joanna
Joanna,
Seymour.
if you maybe want to...
Yeah. Sorry, I'm Joanna Seymour. I'm a project manager for an organisation called Warm Wales.
So yeah, we are delighted to be here today. This is our first time doing a duet together. So we're very excited about this, and we are here to chat about digital, about social prescribing, and about the impact on social care and home care. So just kicking off then, a quick little bit just about Elemental. So Elemental is a tech for good company. It's based here in Derry in Northern Ireland, sunny Derry, and it's led by myself and Leanne Monk. We're a team of 30 people who genuinely care about community health and about halting health inequalities across the world. So we set up Elemental many, many years ago for three main reasons. So we saw from our experience as community development workers that people needed more than just being handed a leaflet and being told to stay active, eat well, and look after your mental health. So we knew that it wasn't as easy as that. So people needed more help, and there was different times in people's lives when they needed a bit more support and guidance around that. We also knew that there was so much support in people's communities that they didn't always know about what was available, and they needed help to actually engage in, maybe it was the men's shed, or it was the walking group, or it was debt advice and things. And we also knew that the true impact of connecting people to all these different programs and services and support that's available wasn't really being recognised by commissioners and people who make funding available for groups and teams and things like that. So who do we connect then? We connect health, we connect housing through our Elemental platform, we connect local authorities, we also connect people in prisons, in the community and voluntary sector, and in domiciliary care teams, and more recently in secondary care, social care, and universities. Because we know that there are people there that need support with better mental health. There are people that need to be feeling less socially isolated, more physically active, and people want to stay at home for longer. So we work all over the UK and Ireland. We're looking now into some new international markets, so I might have to pick up with some of the other speakers in today's session. So just to give you a quick overview before Joanna starts chatting about how Elemental would work. So imagine if there was someone who's recently been discharged from hospital, and so we always talk about Oliver. So Oliver had a stroke, recently discharged from hospital. He's back in home, but he doesn't have much family around him, and he's a bit anxious, and he's not been able to keep up with his rehab program. So using Elemental, a referral would be made for Oliver. So it might be a social worker or Oliver's GP who would make a referral for Oliver, and that referral would be sent over to a link worker. So social prescribing link workers are there now in the community to be able to support people and give them the help that they need. So the link worker would be able to have a chat with Oliver and be able to set some goals, take some baseline measures, put that all onto Elemental, so they'd get a good real overview in terms of what is important to Oliver. Then they would look at some of the great things that were happening in the local community. So there might be the stroke rehab program, there might be some debt advice, there might be a peer support group as well. And the link worker would connect Oliver and use an Elemental to those different services. The link worker would come back and meet up with Oliver and then have a call with Oliver, see how Oliver's getting on, maybe take some scores again, start to see how Oliver's feeling, has it made a difference to him? And as a result of that, Oliver would be feeling less anxious, less socially isolated, and he's confident to keep up the rehab program at himself. And what impact would that have? That would mean that he would be reducing his chance of being readmitted into hospital. He'd be energized, empowered, and mobilized. So then Leanne and I says, look, we need to measure the impact of this. So we made sure that Elemental could collect all that information and report back to say, what's the impact on Oliver and the patients? Is that as activation levels, his well-being is improved, he's less depressed and isolated? What impact does it have on the community as well? Where are referrals coming from? Are they coming from social care? Are they coming from home care? Is it from secondary care? Is it from volunteers? And then what impact does that have on the health and social care system? So less GP appointments, maybe A&E appointment reduction, and reduction in hospital readmission as well. That's just a little quick overview from myself. I'm going to hand over now to Joanna, who's going to give you more of an insight into how they've been using Elemental in their organisation.
Okay, thank you very much. Yeah, hopefully I can give you more information about how we're linking with Elemental. I'm just going to start by saying, so Warm Wales is a community interest company supporting communities around Wales with energy saving advice and fuel poverty support, and we've been doing that for the last 15 years. And we look to support residents to get connected to mains gas through the Warm Homes Assistance Scheme. We look at energy switching, fresh vulnerability mapping, which aids better targeting. We make partner referrals, and we carry out projects called Healthy Homes, Healthy People. Next slide, please.
Oh,
sorry. So if we have a look at the crisis circle, so if we look on the left, this looks at say a visit to a GP practice because someone's got ill health, along with them, sorry, the slide before, sorry, along with them having and living in a damp, cold property. Sorry, can you go back to the slide before?
oh, sorry.
Is that right?
Oh, sorry. There we go.
Brilliant. So yes, if we have a look at the cycle on the left-hand side, it's looking at visit to a GP practice. Somebody's got ill health, they're living in a cold, damp home. And we all know that the impact living in a cold, damp home can have on a health and well-being, and that the need to have a safe, sound, warm, secure home will enable us to live in a home for longer. If we then look on the right-hand side, we'll then see that we start including questions into any consultations that you might have with a health professional. Questions such as, is your property affecting you or your family's health? Is your property cold or damp? Are you struggling to heat your property, or are you struggling with money? So if we include these questions, just imagine the difference that it would make. And it could then have an impact on reducing and increasing and speeding up the discharge process, reducing A&E admissions, and obviously if we start doing home visits. So if we move on to the next slide. Okay, so obviously we need a solution if people start asking those questions. So the solution is Healthy Homes, Healthy People. And Healthy Homes, Healthy People looks to tackle fuel poverty, improve health and well-being, and reduce avoidable health inequality. And we look to give residents healthy homes, lives, and communities by meeting residents to ensure that their basic needs are met so that they can fulfill their potential. We look at engagement, education, and empowerment, and that we want to ensure that everyone has access to safe, sound, secure, warm housing where they can grow, work, and play in. Obviously, what we do and how we do this, we used to do it in home, we used to visit people face to face. And obviously with the speakers that we've heard previously, that's all changed and we need to look at a different way. So we have been using the telephone and we've been able to provide that support, and you'll see a small slide with the support that we've been able to provide. We've been working closely with local authorities, with health and with the voluntary council. And we've started working with an organisation called Flintshire Voluntary Council, where we take referrals from people who have been impacted by COVID-19, either through social isolation or other things, and they need access to shopping and prescription collection. If I have the next slide, please. So you'll see from the slide, in April, we received 155 referrals, which to some people that doesn't seem many, but to us we're a very, very small team in North Wales, and that is a massive increase in the number of referrals that we're normally getting. We've made 259 calls, and obviously with the previous speaker when talking about isolation and loneliness, obviously those calls that we've been making have made a massive difference to those people. We've made 405 interventions, ranging from befriending, support with energy bills and reducing their outgoings, to looking at food parcels and prescription collection. So this is all good, but this is now where Elemental comes in. So if I can have the next slide, please. So obviously being able to have access to Elemental is really, really good and really, really helpful for us, because it's really being able to demonstrate the difference that we are making, and that we are able to look at baseline data to be able to measure the well-being of the residents that we are supporting. And especially at this time, we're able to look at the measurements before we've started helping them, during and after, so we can see a real difference and improvement in their well-being. And then if we move on to the next slide. And obviously the benefits with having Elemental is that all of those interventions that I was talking about before, we've been able to put in one place so that we're able to provide a really, really easy to understand plan of what we can do and what we can provide for those residents. And again, we can really see the progress that has been made. In North Wales, we are lucky that we are a pilot in North Wales, which is in partnership with Betsy Cadwaladr University Health Board. And obviously during this time, it really means that we are able to demonstrate and see the difference, the impact that COVID's having on people, but we're also able to use this technology, digital technology, to be able to demonstrate that the impact, that we're making. And obviously, I just want to finish by saying that as we are spending more and more time at home, it's even more important that we start making sure that we're looking at the home conditions, because obviously, as we all know, and as I've said before, the impact of somebody's home, the conditions, whether or not it's cold, whether or not it's damp, whether or not they're able to afford to put the heating on, can have a really, really big impact. And I think now, looking at COVID and looking at this, is that we need to be looking at that a lot more. And just to finish, for me, it's really exciting, the opportunity that we have to link more with Elemental and to become more digital. Next slide.
Yeah, that's great. Thanks, Joanna. And yeah, we're really excited about working with Warm Wales and how we're going to help them to deliver on their objectives and scale and better measure all the great work that they're doing. Final slide from me is just really the future is about continuing to connect people and build communities, improve their lives. Integration is a big thing as well. So we integrate with clinical systems, and we're just about to start integrating with some social care systems as well, which we're really excited about. We're looking at linking the data sets from social prescribing with health and social care data to see what are the true impacts that social prescribing is making on health and home care and social care. More shared learning. There's lots of things that we're always like, there's lots of different approaches people have been using in different projects. So our website has lots of information there, and new international partnerships, which is why we love the European Connected Health Alliance, and we love the pop-up systems, ecosystem events, and we'll be picking up with some of you later. So thank you very much, everybody.
That's fantastic to hear, and I think it's a really nice way of talking about some of the impacts that solutions can have for existing services. So thanks both of you for that, and interesting to see your solutions being tried there in Wales as well. Oscar, what can I say about introducing Oscar? Oscar, if you could turn on your screen, please. Wonderful. Just by way of introduction, I've worked with Oscar for many years now, and I'm very proud to welcome Oscar along from ISRA, one of our partners in our European programs, and hopefully soon to be our first ever Italian ecosystem. So Oscar has very kindly agreed to come from Italy and speak to us today about the services they've been providing during what's been a very well documented period of stress and demands in Italy. Oscar, if you can speak, then we know your microphone's on.
Yes, thank you.
Wonderful,
Andy.
over to you.
Okay. Thank you, Andy and colleagues, for this invitation in this webinar. I'm Oscar Zanutto, coordinator of Faber, that is an innovation hub based in Treviso, in the northeastern part of Italy. We are just a few kilometers far from Venice. So our contribution today about how we are dealing with this COVID-19 situation will be presented here. So please, next slide. The next also, please. Okay, so what we have done is mainly two things. One, we have a specific dementia care center in our public body, that is ISRA. This is the name of the institution. And we usually deal with problems related to dementia disease with a team of psychologists and other practitioners, and we support families around Treviso municipalities. And the problem is how we can still running and deliver these services that are giving information, running group activities, consulting, And this SAPAD is a specialized support for people with Alzheimer's disease with, let's say, environmental and behavioral adaptation at home, and consultancy, and running Alzheimer Cafe. So when all, let's say, was locked down, and we are, to be honest, in the middle of a situation nowadays, we build up Facebook streaming groups, and we moved online with our actions. So in particular, next slide, please. So we did Alzheimer Cafe. We moved online with meeting in a monthly basis dedicated to caregivers, supporting family members, presenting how to deal with the early symptoms or an ongoing situation about dementia. And the numbers that we reached out are quite interesting, because during the streaming meetings, we have around 50 people. At the beginning, it was quite difficult for them to use, let's say, Facebook in having access to streaming, but it works. And also, we deliver several post tutorial information that reach out around 3,000 citizens and caregivers in the local communities. You should know that Treviso is not so big. It's 80,000 citizen inhabitants, so it's a good number. Also, this consultancy about SAPAD for people with Alzheimer's disease.
Oscar, you can just put your microphone next, just a little bit closer to you, please, if possible. That's better.
Yeah.
That's better.
Okay. Sorry. Thank you. And we moved also.
Carry on, Oscar.
Okay, online, and so psychological support was one of the main things that people really appreciate. So this is the way, very simple, very concrete, that we use to move in online and virtual approach for informal caregiver support. Next slide, please. Okay, so with this support, we also present specific sessions with not only tutorial, but also books and paper that could give and provide information, but also the stimulus for conversation. So, you know, we have to build communities and support in between and within the communities. So this is what we are doing. Next slide, please. So pro and cons, what is positive? We notice that there are deeper reflections in online meeting rather than in face-to-face. So maybe people feel more free to be, let's say, concentrated about emotions, feeling, and so on. Also, for practitioners, they can revise their live performance, so they can have feedback about how they are running those groups, and we can still, let's say, and keep going and supporting people anyway. The negative dimensions and aspects are the difficult to work without feedbacks from the real public and the real interaction. There's a bit of fear to be more judged in terms of, let's say, the word and the approach that you have. Some technical troubles, as usual, moving people with low digital skills and difficulty in reading commands and interaction. So you cannot chat while you are presenting, things like that. But essentially, it works. So now we can move to the other experience that we would like to share. So please, next slide. That is Portale Parenti. Portale Parenti, it means relatives portal, that is an informal and remote communication with caregivers. Let me say that when we locked down everything in the around the end of February, nobody in terms of informal caregivers could step in the nursing home, and nowadays it's still to be like that. Maybe next Monday we will open again the situation. And so loneliness and limitation in conversation and in getting information from older towards relatives and vice versa, it was and it is a problem. So next slide, please. Thanks to Portale Parenti, we gave the habilitation, thanks to an app that informal caregivers could use to manage communication, also with providers and patients, gather also social and health informations. It works in mobile solutions with a full privacy, let's say, compliance. Next slide, please. And the most appreciated functionalities is for sure video and chatting with them in a specific channel, very protected, dedicated, where they can asking about how it's going on, how people feel, and so they could be 24 hours a day connected. So next slide, please. This is very important, the activities and vital parameters, because usually the concerns of relatives are about how is the food nutrition of people, movement, rehabilitations, and so on. So they can immediately get access to this information without, let's say, asking to nurses or rehabilitation workers. So we can set up a specific privacy profile for data access from remote to the son, the daughters, the lovers, whoever, and they can log in. Next slide, please. Okay, so yes, this is the main contributions with these two experience, and let me be very thankful for your involvement and the opportunities to share what we are doing in this COVID-19 times. Thank you very much.
Hi everyone. Yeah, so my name is Lee Omar. I'm the founder of Safe Steps, and we're a digital health app that is used in care homes, and I'll talk about that later. I'm also an NHS, National Health Service Innovation Accelerator Fellow, which means this year and for the next 3 years, the NHS are helping us scale our technology into their system. Next slide. Yeah, so besides running a technology company, I'm also a non-exec director of a group of care homes in Greater Manchester. So I really do have a good understanding of the challenges of care homes, because I'm legally responsible for 450 of our residents. So I've been kind of on this agenda for quite a few months now, before it kind of hit the UK. What I've been doing at the care home group for the last year is bringing in a culture of research and innovation, and we set up a innovation lab. So we've kind of started to get our homes to be quite techy, and that's really helped us be resilient in this COVID crisis. Next slide, please. But yeah, a quick bit of background about why I set up Safe Steps, which is a spin out from my other company, Red Ninja. Here's me and my granddad. I used to be a carer for my granddad. He was one of my best friends, and after my nan died, when he was living on his own, he had a fall in his house, and that fall caused him some major injuries, and he died shortly afterwards. So the problem which Safe Steps is trying to solve is, how do we prevent falls in our aging society? And it's to try and help families and help people like my granddad. Next slide. So yeah, Safe Steps is an app that carers use in care homes, and it has one goal, and it's to prevent falls, because falls are a massive problem in our aging society, and they cost a lot of money, with people having to go to hospital with hip fractures and broken bones and this type of thing. Next slide. So yeah, we co-created this app, and with carers and families and care home managers and clinicians, and we've now scaled it to over 100 care homes in the UK. Next slide. And the way it works is it digitalizes an old paper process. So every month a carer does a risk assessment, and the app spits out a personalized prevention plan of things to do to reduce the likelihood of a fall for the whole person. Next slide. So yeah, that's what Safe Steps does, and we were going along quite nicely. We're on this NHS innovation program, so we were starting to scale across the north of England, and then COVID happened, and all our kind of orders from the NHS and the kind of the sales dried up, and we had a choice of do we kind of shrink the business down? We've taken on a lot of people. Do we furlough these staff because these staff were taken on in anticipation of our growth and the new deals that we had, or do we try and pivot the business? So about 2 months ago, maybe the first week of kind of COVID really hit in the UK, just before maybe the schools closed, we spent a day, all our team and some of the clinicians and carers we work with, and we thought, well, we've got an app which is in over 100 care homes. You know, it's being used tens of thousands of times. It's being used daily by thousands of carers. Could we use this as a kind of media channel, or could we use this as a platform to help prevent the spread of COVID in care homes? So what we did in this hackathon was we created a new prototype, which was a kind of COVID tracker product, and I'll talk about that next. So next slide. So we sent the prototype to the NHS and the innovation parts of the NHS that we work with, and some of them took it up, and we further developed this prototype, and it was all around helping carers spot the symptoms of COVID. Next slide, please. And these the data which the carers put into the app is connected to clinicians and epidemiologists, so they can help manage the spread of COVID on a geographical basis, but also it allowed the clinicians to know exactly what was going on with each individual in the care home. So it was a kind of RAG rating. So if someone was flagged up as red, that meant they had a lot of COVID symptoms. If it was green, it might have just been 1 or 2 symptoms. If it was blue, it's that they had no symptoms. We put some extra kind of medical indicators in there because for our older population, sometimes they might not show any symptoms of COVID, but they do have it, and their lungs are filling up, and they can die, you know, within 48 hours, and with it not looking like they've got any symptoms. So we needed to get extra medical knowledge rather than just the COVID symptoms, which we all know, you know, cough and aches and that type of thing. So this new app was developed, and within 2 weeks it was in a small number of homes. Within 3 weeks, the clinicians had their dashboard, and we're now in the process of scaling it to 560 homes across the north of England. Next slide. So yeah, this is kind of just a screenshot of how it looks for the carer. You know, they just click on the name of somebody, input the symptoms, and we've digitalized that knowledge. There's a big lack of testing available for care homes, so this is the most up-to-date information that we've got on a lot of older people. Next slide, please. So yeah, this is just another slide of how it looks for a user. So it's just all around getting as much information about the residents as possible. So it relies on a carer kind of just taking observations. They don't need to be a clinician. And from those observation notes, we can turn it into kind of clinical data, which can really help save lives. Next slide. So this is a view which like a care home manager might have, so they can see a kind of data analytics of all their residents, you know, so they can kind of spot where the problems are, who they need to isolate, how they manage the spread of the infection, so an infection control. And that's been live for over a month now. Next slide. So yeah, this is a snapshot of the dashboard which the epidemiologists are using. So in absence of good data around testing and track and trace and all this stuff that you're hearing, this is kind of really good, real up-to-date data, which is changing in real time. So this gives an accurate picture of what's happening in care homes, which are, you know, very difficult to get access to. You know, they're all locked down. You can't really go in them unless you're staff, because there's such a high risk of spreading the disease to this vulnerable population. So yeah, that's been live for over a month, and that's also helping the clinicians move people onto the right care pathways. So it's been saving lives, and we've been told that the data says it's already saved around 400 people's lives who wouldn't have been put on the correct care pathway because the doctors and the GPs didn't have the knowledge of the patients. Next slide, please. Oh yeah, so that's my presentation. You know, a quick run through COVID from a startup point of view, the problems and also the opportunities to pivot to try and use our technology to fight the spread of COVID. So if anyone would like to get in touch and have a Zoom, there's my email address. So thank you very much.
Thanks for that, Lee. Great to hear from you again. As I said, I've got a long experience of working with Lee and thoroughly recommend you making contact with him. His adaptability is legendary, and that's good to see this is happening now. And it's really, really impressive to see a positive impact so quickly, especially for someone who's stuck in New York. So hope to see you back in the UK as soon as we can. I'm going to move on very quickly. People can make the connections they can. I'm going to make that legendary shout out to Teresa. Teresa, what time? Can you hear me?
Yes, I can hear you. Thank you for your patience.
Excellent. We're going to switch some slides around for you. And then when you see them, we're going to press on with yourself because we're just going to catch up on some time. And I'm going to go on mute. Over to you.
Okay, first just to introduce myself, if you go on to the next slide there, Andy, please. My name is Teresa Morrison. I'm the Clinical Director of Connected Health. I'm a nurse by profession and I have a Master's in Dementia Studies. I'm responsible for all the clinical and training functions across the entire Connected Health group. Just the next slide. So through the session, I'm just going to discuss a small background about Connected Health and what we do, and discuss the impact that COVID-19 has had on our business, paying particular attention to 3 areas, which are recruitment and training, the daily operations, and then personal protective equipment, and finish off with what we believe the way forward is for Connected Health. Next slide, please. So Home Care Connected Health are a home care company. We provide domiciliary care to people living at home to enable them to live at home longer. That may be assistance with particular tasks such as personal care, continence needs, just being able for them to maintain their independence and quality of life. We believe that it's in any intervention to improve the health and well-being of a person. In more recent years, there's been a lot more clinical tasks that have become home care, and that would include stoma and catheter maintenance, diabetic management. So it's shifted dramatically over the past number of years, which is why it's been equally as important to help people live at home for longer, with a lot more training and education put into the social care staff. It is a fully regulated industry with inspections and commissioner audits and oversight, and all employees are registered with the social care body. Next slide, please. So Connected Health in numbers, we're an all-Ireland provider, and we also have an office in Liverpool, England. We provide over 2 million care visits per year and have over 700 employees. We have a well-established training division, Connected Academy, with accredited training programs across the board. Next slide, please. So the impact of COVID on our business. Initially when COVID-19 had been released in the media, there was a lot of panic with our staff and a number of clients. And straight off, what we done was establish a command and control group, just to ensure that we had regular communication with our clients and also with our staff, just to ensure that we were providing enough reassurance of information that we were aware of and reinforcing trust with our staff and our clients. That command and control group dedicated a process of client and employee health monitoring. We had a number of clients and employees who were suspected symptoms of COVID-19, and we ensured that we followed the process and offered as much support as possible to enable them to self-isolate or receive the help that they needed. We also participate daily in direct communication with our commissioners, which is our trust and the health boards. We also have direct communication with the health minister and senior government representatives. We work together with the other providers just to ensure that we had continuity across the board, and we wanted to secure parity for home care and nursing homes alongside the NHS. We worked with the Social Care Council to secure that parity, and if you just go on to the next slide, we have a short video just to show what we had worked towards with the Social Care Council.
We may have to hit a sound button here, I think. Hang on a second.
Okay, well, if we can't get the video, yeah, that's fine. Basically, what the video shows is it was an advertisement to allow all social care and home care workers be aware that they had priority access to supermarkets, particularly Asda. It was known that obviously with the restrictions in place, social distancing, there was, long queue backs for the likes of supermarkets, and our home care workers were equally as under pressure as the NHS workers. There was a lot of shops that introduced priority shopping for NHS workers, and we worked with the Social Care Council to allow all home care workers and nursing home workers to be allowed that same access. So it did definitely ensure parity with those other boards. If you just move on to the next slide. So just going into the three main areas which COVID-19 has impacted, starting with the Connected Academy, which is our training division and includes recruitment. So with our regulatory body, we would have had face-to-face interviews, face-to-face training programs over a 3-day period. It was a longer process, and it was a long process to mobilise staff onto the ground to enable to reduce pressures. COVID-19 has changed that dramatically, as we are now allowed to do video interviews, online applications and online identity verification to allow the access NIs and the police checks to be approved much quicker. We now have changed from face-to-face training over a 3-day period to do online interactive version. We have a Connected Academy online training platform, and we have all our accredited programs on there, and it's easily accessible for all the potential employees and trainees who hope to come on board. It gives us the opportunity to mobilise them much quicker and ease the pressures out there for both home care, but also for the hospital environment to enable discharge into the community and allow people to live at home. We have one element of it, which is the manual handling, which is usually observed by a trainer on our training site. However, with the restrictions of social distancing, that wasn't to be, and we now have been allowed to do that while the person is employed and out in the community. So essentially, the area manager, which is the manager of that team, and a trained member of staff will observe the trainee in a person's home. Which allows us to ensure that the person is doing the manoeuvres correctly, but also allows us to mobilise that person much quicker. The refresher training on the platform is automatically issued through the online programme. It is just allowed for quicker turnover, and it's been working fantastic. If we could go on to the next slide. So the operational impact. As I mentioned, there was, when COVID had sort of went out in the media, we had an initial increase in clients declining calls. And what we've done operationally has been to introduce telecommunication services. So those clients who were declining face-to-face calls, we have enabled them to receive telephone calls. We also introduced Zoom calls for this, so we have made it online and interactive for the client, just to ensure that those tasks that were due to be carried out face-to-face have been able to. That would include medication prompt, ensuring that the person at home has eaten and drank, and also including them in the social stimulation and having that outreach to somebody who they can trust. This also allowed us to reinforce and provide reassurance to the clients and to ensure their safety. And in time, after a few days of having telecommunications, quite a lot of the clients actually came on board and asked for face-to-face calls to be reinstated, which was positive for them and also positive for us. The operational impact, we were able to monitor suspected cases from clients, as well as staff, so we were able to monitor the progress of that, and we supported them emotionally and physically to ensure that they were supported if they did suspect COVID-19, and that we enabled them to receive tests, and if positive, then supported them over the telephone with what they needed to be doing on a day-to-day basis. Those cases who tested negative, again, were given support to reassure them that there was going to be measures put in place to reduce the likelihood of them becoming infected. That's both for the clients and also for the staff. We enabled the Human Resources Department to carry out return to works to enable faster turnaround. And with the changes through recruitment and online training, we were able to double the impact of our clients, of our staff coming on board. And we were able to effectively double the recruits coming through, which helped us to relieve the pressures on the ground. On to the next slide, please. Additionally to that, we were able to input remote working practices through the use of technology. We included daily contact with service commissioners to ensure that we were following the guidelines, particularly in relation to PPE, which I'll talk to in a few minutes. talk about in a few minutes. We increased the capacity to alleviate the pressure on hospital discharge. So with our enhanced training and PPE measures, we were allowing early discharge from hospital, which obviously relieved the pressure. We established dedicated COVID teams across all geographics, which again allowed the early discharge from hospital to ensure that they were being cared for in a more clinical environment with appropriate PPE. We introduced regular employee communication and again maintaining that trust and reinforcing reassurance. We provided ID letters and care stickers just to ensure that through the lockdown, our staff were able to easily mobilise around the local community and get the clients at the correct time. If we can move on. So just on the PPE, so this is personal protective equipment, and usually in home care we would be, our normal PPE would be gloves, aprons and goggles if there is an infectious diagnosis there from discharge of hospital. Obviously, with COVID-19 coming on board, the initial limited resources was apparent. Our existing suppliers had been seconded to NHS, so our supplies had been redirected, which obviously begged a big challenge for us as a business. At that point, at the very start, there was no real support from commissioners. So as a business, we had resourced our own suppliers and purchased from different countries to ensure that we had enough to protect our staff and also protect our clients from risk of infection. Through the commissioners and also the Public Health Agency, the guidelines changed frequently and they varied from trust to trust. So for example, in Northern Ireland, we deliver care in the 5 trust areas, and every trust was a different set of guidelines to follow, which was difficult for us to enable our staff to collect their PPE appropriately. What we done was we centralised our procurement and distribution centre just to enable that the right measures were followed at the right time, and we took all precautions. We joined par with the other providers to ensure that we stood together as a force in home care to protect the clients in the community. All the commissioners providing the PPE as of now. Some with conflicting guidelines still continue. However, we are definitely been able to receive enough PPE to cover our own staff and to protect the clients. It's an ongoing campaign, and I do believe this will continue for some time. Next slide, please. So basically the way forward, we will continue with the online recruitment process. We are a regulatory body, so post-COVID we believe that this will be reviewed, and it's about us being able to present that this has been the most effective way for us to recruit people, to train people, to enable them to be mobilised faster. We do believe home care will become a party with the NHS and enable us to allow for early discharge and ensure that people are being looked after at home. A lot of with our command and control group, what we done was we created the close monitoring to allow us to provide statistics post-COVID. So for example, at the minute we have over 700 employees who work for us, and we had a number of employees who were tested for COVID-19 as they had suspected symptoms. So there was 54 of those who we sent to be tested, and only 7 came back positive. Alongside that, we had a lot of training and the PPE enforcement, which has definitely improved their likelihood to contract the COVID-19. This has enabled us to monitor and track what the outcome will be. Going forward, this will continue until we have a solution otherwise. Increased PPE will be going forward. The continued communication with the staff and also clients improves the team morale, of course, and reinforces with the clients that they're reassured and they feel protected. And we will continue remote working for the admin roles, which will ensure the telecommunications for clients and the staff will continue. So that's really, you know, everything from myself, and I hope you enjoyed the presentation.
Thank you very much, Teresa. And if anyone deserves, if we had a big audience and live here, we get a big round of applause for perseverance, for technical fun and games, as we call it in English. I think that's a really good case study there of how one of our members certainly has met the challenge of COVID-19. So thank you very much for your input there. Certainly coming up with novel and new approaches to what is a tremendous challenge. I just want to quickly ask, because we've run out of time, would all participants who are still able to show their screens, please, if possible? I don't know if, I know Jen's had to go, but Theodore, Teresa, Stephen, Jennifer, it's gone, Joanna, Oscar, if possible, and Lee, we're running out of time for questions. I don't know if Theodore's still around. Theodore, are you still there? Hey, I don't know if he's still there. But thank you, all of you, for persevering, which is what's been, as with all of these things, quite a technically challenging session. I think what we've shown you in just over 90 minutes is about as big a picture as you can get across both Europe and even into Canada. And actually even daringly down into New York as well. So thank you very much for your input, Lee. Oscar, thank you very much from Italy. Teresa, thank you very much from Northern Ireland. Thank you, Joanna from Wales. Thank you, Stephen from Canada. And thank you, Esther, also from Spain. Thank you all for your time and your patience. We will be sharing this and slides and material following this session, and we hope to speak to you all very, very shortly. Thank you very much. And for me, and the last wave there, thank you very much. All right, goodbye. Thank you.